Good evening to all of you. Maybe there are others on different time zones. So anyway, a good day to all of you. I want to start my presentation firstly by thanking the OPTAA governing body. I think this is a brilliant initiative to conduct monthly webinars. And I especially want to thank you for proposing my name as one of the speakers. And it's a pleasure to be back with CMCI. So I've been really out of touch for quite some time, except for a few of you. And I want to thank you for this opportunity to share my experience, in this journey in geriatrics as well as long-term care. And it's a pleasure to be with you all again. Many of you may not know me. My name is Lincy Mariam Thomas, and I'm an ex-CMCI batch of 1985 for my bachelor's, and I did my master's in Bombay in 1995. So the topic I'm presenting today is the OT role in geriatrics and long-term care. So I have no disclosures. These are just few pictures on the Arabic culture, a glimpse of their attire and what they generally do. Apart from this rich culture of theirs, most of the people here, the local nationals I'm talking about, are people who are having busy social lives as well as professionally, and some of them do not have people to look after their loved ones at home. So the initial part of the years as long-term care, many of them were just admitted into the hospitals and left there for the hospital healthcare workers to look after them. Many of them with various disabilities, limitations, and different conditions. And these were the type of patients who required continuous and consistent help. So these are some of the social reasons why many of them left their loved ones and were left in the hospitals, and some of them, of course, even for respite care. I'd like to just show you an overview of today's presentation. Just an overview of Hamad Medical Corporation, as well as our occupational therapy specialty areas. I'd like to just share about the accreditation standards, the introduction to our geriatric settings and residential services, some of our documentation standards, assessments, how we categorized our residents, and what are our treatment goals, interventions, the community rehabilitation services, challenges, and achievements. Hamad Medical Corporation is the largest healthcare provider. Under this corporation, we have 16 hospitals, and they've really expanded quite a lot. And then some of these are the northern hospitals which are yet to begin. Coming to the various specialty areas that have, this is across HMC facilities. We have the acute care units, the adult neurological units, geriatrics and long-term care services, residential services, seating and mobility services, and the community rehabilitation services. They are actually providing their services to the whole state of Qatar. NICU, pediatrics, mental health, community mental health services, hand therapy and burns, cardiac OT, OT in oncology, and of course, community equipment services is a big chunk, which is a part of what we do here in long-term care. Coming to accreditation, just like any hospital and institution are accredited, I'd just like to tell you that we got accredited by Joint Commission International in 2006, and we were following the hospital standards. The long-term care standards of JCI was initially established in 2012, and we were the first facility, the first country in the Middle East who got accredited for this long-term care. The standard started in 2012, after which the center which I'm working in, we were part of this long-term care standards. The most recent certification that we've had is the person-centered care, which is under the Planetree organization. And there are 3 levels of, being certified, as well as just want to tell you that this Planetree person-centered care has created a big change in the attitudes, in the cultural way of looking at things within the hospital organization. Person-centered care is to do with focusing on person's interests, their preferences, as well as the well-being, be it patient, family, or the healthcare workers. Staff wellness and staff well-being is a major part of this process. One of the things that is emphasized in Plaintree certification is that some family members are selected to be part of the Patient and Family Advisory Council Committee. And it's these family members who are the voice of the patient. So whenever they require something or they feel there is a lack of something within the facility, they bring it up to this committee, and then the executive administration, as well as the team leaders within this committee, they are the ones who actually work on it, create action plans. And I think this has really helped us in our journey here. Coming to the documentation standards, we have HMC's policies and protocols which we follow, and we also do our documentation on the online Cerner system. We have assessment forms and documentation which is done for all our reports and records which are found online. And one good thing is the continuity of care even from other hospitals can be found, and that was the basic reason why we went on to this. So this has been extremely helpful for us to view what has been done in other facilities. This is where I started. This was about almost 11 years ago. Can somebody tell me, when you look at this picture, at least for me personally, I have never encountered such patients in India. I don't know if any of you have seen. If you can tell me what your experience is, if you were given a patient like this, please share your experience. I'd love to hear this. Anybody? Okay. So let me just give you a brief idea about what happened when I first, saw these patients. We had a whole unit. So looking at these patients, what do you do when you don't know what to do? Or if you don't know something, is it something to be scared about? Or do you want to learn from this? It's very easy to complain and say, why am I in such a setup, or what am I going to do? Let's not try to find faults, but find a remedy. Before I move on to the history of how we evolved in this long-term care, I need to acknowledge Miss Angela Pilski. She was a Canadian OT and specialized in seating and positioning services, and she had extensive experience in the long-term care. When she came here, she was the one who actually guided me and helped me, in terms of resources, how to go about treating these patients, because this was something totally new for me. So just to give you a background on how we have come through in Qatar, the long-term care unit was a part of the first hospital in Qatar, which is Rumaila Hospital. And like I've written here, institutionalized long-term care patients, their length of stay was something between 12 to 15 years. In 2010, the first skilled nursing facility was established. We had about 86 patients. Most of them were male. And then gradually, they started with one unit at a time, and they had 4 units or 4 wards, as we call it, in the skilled nursing facility. By 2014, we had the second skilled nursing facility. And being an Arabic country, they wanted to change the name. And that's how Inaya Specialized Care, Inaya and Dam, Inaya means special care. And that's exactly what they did to, they just changed the name from skilled nursing to Inaya Specialized Care Center. The type of residents are both male and female. We have tracheostomy units and ventilator-dependent residents. And over these years, the length of stay has come down drastically to maximum of 1 to 2 years. We do have some who stay on little longer, but it's definitely much, much better. So looking at our geriatric care settings and the residential services, I've actually highlighted the service in which I'm working in, and that is Inaya Specialized Care Center and Dam Specialized Care Center. The residential care compound, I've also highlighted it because these 4 facilities are all part of the residential services which are following the long-term care standards of JCI. The various diagnoses of adult and geriatric patients that we have are stroke, TBI, SCI, degenerative neurological conditions. We have the tracheostomy units, ventilator dependent, Alzheimer's and dementia, fractures, orthopedic conditions, palliative care, and end-of-life care. Of course, most of the patients that we have are with multiple comorbidities and complexities, but the scope also has changed over the years. Looking at this, can someone tell me what you think of your quality of life if you were lying in a hospital just alone? I think most of us have experienced what this pandemic has done to us. We have all experienced what it means to be in a lockdown, not able to move out of the four walls of our home with restrictions, children and family members all some of them frustrated, not being able to go out. Life had just changed completely for all of us. And our perspective to life has also changed along with this over the past 2 years. So why don't we just imagine thinking of a patient, a resident lying in a hospital without family members, physically and mentally challenged, staying within the four walls of their room. This picture is a classic example of what it looks like in a room in a specialized care center. It's a beautiful looking room, looks more like a hotel room, state-of-the-art facilities, and yet there they're lying alone. Very few have caretakers to look after them. So one difference we wanted to make from hospital to these residential services was to improve their quality of life. Just giving you a little background on from the time they are admitted right up to discharge. So we do assess these patients using the standardized and non-standardized assessments for both functional and cognitive assessments. We do the FIM here, though we know that it is not completely useful in terms of us being able to relate to their functional abilities being long-term care patients. We are also using MOCA, MMSE, and other cognitive assessments depending on the ability of our patients. We have an interdisciplinary plan of care where we document. Now, just to give you a brief idea on the long-term care services, from our initial point of contact is within 24 hours, except when it's on a weekend. We do not have an on-call or continuity on the weekend to see a patient. However, within 5 days, we complete our initial assessment. And within 7 days, we have an interdisciplinary case conference. During this case conference, all the disciplines involved report their plan of care, and then a collaborative decision is made regarding how to go about the individual's plan of care. The other thing that we focus on is having discharge planning done at admission itself. And the main reason being, so we are able to look forward to, especially if they're non-Qataris, the patients may be, these residents may be repatriated to their own home country, or maybe they're transferred to another hospital in their country. Whereas for those local nationals, we actually do safe discharge planning. Home visits are being done and suitable equipment is being ordered and recommended for them before discharge. This is our OT assessment on the various aspects that we are looking into for these patients. We had a tough time categorizing our residents because initially we had a lot of comorbidities and complexities of these patients who were lying in bed for many years. So the easiest for us was to classify them. Over these years, that is over the last 3 years, we've come into a kind of, we've prepared a guideline to categorize our residents. One, according to the period of illness, and second is their level of their functional levels. This is just a flow chart to show you, which is a part of our guideline on how we have actually categorized our residents. Now, in all the geriatric facilities, in Rumaila Hospital and the others which I had shown earlier, we do have acute patients, subacute, slow stream, and long-term care. In the long-term care, we do have active patients who are admitted, like I said, for social reasons. There are some who are low functioning, who may have poor to fair motor skills, but they are alert and they may or may not respond and follow commands. But they are totally dependent functionally, and with cues and prompts, we're able to actually gain responses. One thing about low functioning, the low arousal and complete bedbound, all the categories of these residents are actually mobilized onto a wheelchair. Low arousal and complete bedbound, there's only one difference. Low arousal, again, they're awake, but these residents have poor motor skills, they're not alert, and there are no meaningful responses. But low arousal are fit for seating, so we do move them out for physiological reasons and other, just to keep them going, whereas complete bedbound, due to their multiple complexities and comorbidities, they are not moved out and they're completely bedbound. This is a multidisciplinary team. Of course, patient and family is the most important. And along with them, we have the physician, the nurse, the physiotherapist, OT, SLP, RT, social worker, dietitian, the wound care nurse, case manager, and the psychologist. So coming to our treatment goals, of course, we do our short-term goals and long-term goals. Our long-term goals for most of our residents is definitely to see that they to prevent any secondary complications, be it on the bed, for any pressure injuries, or even to maintain and improve their sensory motor and functional goals. Part of the long-term goals is also to see that we can try and prevent contractures through proper positioning. And those are our short-term goals, which I've mentioned above, which is early mobilization out on bed and on the wheelchair, provision of positioning devices, and of course, continuation of this depending on the level of the residents' responses to sensory stimulation, cognitive stimulation, functional goals, doing basic aerial training, comfort care, caregiver education, and safe discharge planning. So these are some of our OT interventions which are being done. We'll start with proper positioning in bed. So few of the things that we do initially when the patient is admitted, if they are anything from low functioning to low arousal, and if they require any devices, we are actually using appropriate sleep system and custom-made devices, which I'll just show you a few pictures. So this is part of bed positioning using these sleep fit pieces for the lower extremities as well as for the upper extremity. Some of these are actually made by one of, he's a staff on our team, he's a tailor, and he's extremely creative, Mr. Sunny, and he's the one who actually prepares these custom-made devices, mainly for relieving pressure. If you see the one which is with, you've seen the one with the foot, these are all mainly when they have any kind of pressure injuries, just to relieve pressure. That's when maybe you have the pinner of the ear or behind the head or other places. These are just some of the devices which he has made. Splinting is also to prevent contractures. We do have ready-made splints, as well as we fabricate splints also with thermoplastics. And different types of hand rolls are provided for hand hygiene and also to encourage finger closure. If they're contracted, of course, we discontinue this, but different types of hand rolls according to how much of function there is within the fingers, this is also provided to them. The next major role that we have here is seating and positioning. Early mobilization and wheelchair proper seating and positioning. So let's look at what is the main reason for putting most of our residents out in appropriate seating is to reduce the risk of secondary complications, to enhance their maximum mobility and functions, comfort care, and efficiency, of course, in the best functional positions possible. Access to environment and safe discharge, whether they are assisted or whether they can move the chair by themselves. Some of the wheelchairs that we have here, I'll just browse through some of the pictures. Standard wheelchairs, MFGCs, striker, geriatric, powered wheelchair. And of course, the seating services that we have, the specialized services, they are the ones who make these molded seating solutions for patients with very severe functions and contractures. Some of the safety belts, some of the pressure relieving cushions that are being used to seat patients out on the wheelchair. And we also have some overlay mattresses which are put on the bed if required. Coming to this early mobilization process, it started actually in every hospital wherever they have available equipment, patients are actually being moved out. At NIA, in our center, one of the things that we do is to explain the process along with MDT. We initiate it along with the nurse, especially for patients who are able to be seated. We try to do this as soon as our assessment is over. Once we know their functional level, their cognitive levels, we actually put them into appropriate devices and the wheelchair that is to be used. Transfers are done using the hoist, and we have the nurse, the physio, and the OT who work together. We move them out initially, check out their as long as their vitals are stable, they're able to tolerate, the tolerance to activity, and even their endurance is looked into. Once the patients are stable and the nurse is confident with the transfer, then they are the ones who transfer the patients and bring them out to either to the physiotherapy gym or to our activity rooms. If the patients are not too stable and only allowed to sit out for a short time, then we start our therapeutic activities at the bedside. Once they come to the gym, then of course, to our activity rooms, we continue our therapeutic activities with them. Some of the other interventions that is provided are sensory stimulation. This is a ventilator-dependent patient with whom assistive technology is being done. Culturally, we do have, of course, males not seeing female patients, but our AT specialist is a male with consent from the family and the patient. If they're vocal, if they're cognitively well, definitely they're allowed to come and see. Otherwise we have, and we always have a female, either the nurse or the therapist along with them. So this is just a picture for her communicating using AT. Some of the individualized training that we do is cognitive stimulation, therapeutic activities, ADL training, recreational activities, AT, and equipment evaluation. So you can see some of the pictures. Some of them are done indoors. When the weather is good, we also take them outdoors. The major part of our activities here in long-term care is activity preparation. One of the things that we do with each resident who is attending is we have an interest checklist which we use, finding out what are their common interests and their preferences. Of course, we have to use culturally appropriate activities. Many of them are Arabic. We do have residents from other countries like Nepal, Bangladesh. So we have a mixed group of patients. So these residents are actually put even according to their languages, according to the communication level. We actually group them and we have different activities for these residents. These are some of the structured task-oriented group activities which are being conducted, indoor and outdoor activities. Show you a couple of pictures. So we've had barbecues outside when the weather is good, movie watching, entertainment. Prior to the pandemic, they were taken out to the zoo, they were taken to the museum, and we've just had socialization near the beach side and them just sitting together. A lower picture here is showing what they do with their posters. Some of them, the female patients make jewelry, and then we've had an exhibition where they're able to actually, we sell it, and this money is again used back for their own activities. Initially, we used to have male and female patients combined activities together, but ever since we've started down, we've actually completely moved into purely cultural appropriate, where the females are being seen separately in groups and the males are seen separately in their groups. These are some special group activities which is done, both physical, recreational, other entertainment programs done by the staff for the residents, as well as staff, the residents themselves actually conducting and performing during an entertainment program. These are some leisure time activities. where the patients sit together, especially on days when they are not scheduled for therapy. There are ongoing group therapy going on in a place called Majlis, which is basically a place in Arabic, which means to sit out, or where council members meet. So this is just a room where we have these activities, ongoing activities for meal preparation and other things going on. Just have a small video showing assistive technology, especially for patients who are in improper position and can actually use the mobile and other things for communication. I just want to tell you how we've reached this far. Our strength has been a multidisciplinary team approach. We've had education and collaborative care, which has actually helped us a lot. We started with the rehab education together, both physio and OT, where we had various educational sessions. We've also educated the physicians, nursing. We've had competencies where all these assistive devices being used both by physiotherapy as well as OT. We actually have conducted training sessions where we explain to them the use and basics on safety techniques, especially on the wheelchair, where the brake is, how to maneuver, how to the different functions of the wheelchairs. This was done for both for splinting, for the wheelchairs, as well as the sleep system. So this was conducted for all nurses in the Anaya facility. And I think that helped because that was the continuity of care needed to be done by the nurses. We have something called an NDT briefing, where all the administrators as well as all the team leaders from the various disciplines meet once a week to discuss any major issues or concerns that need to be endorsed to other members. The safety briefing is something that happens on a daily basis with nursing, but the rehab team, we join twice a week, and all the units are being discussed, especially any resident concerns, which over either family concerns or even if there are problems with the resident and we need to know about it, that is actually mentioned every morning for about half an hour. 6 units are being discussed, and on rotation staff are actually scheduled for this. The other thing that we do is therapy schedules, where patients need to come to the therapy rooms. So both between physio and OT, we try to coordinate, collaborate, and make schedules such that all these residents who need to come out for therapy or to the gym are brought out. The seating schedules are different. Some family members, they would like their loved ones to be seated twice a day or sometimes daily. And this is actually taken up by the nursing, by the head nurse. And they are the ones who, according to their manpower and their availability of or their feasibility to move these patients out, they create their seating schedules for these residents. We have a wound care nurse in all the facilities who look into very closely into the pressure injuries, and they collaborate closely with us, especially when there is a need for any positioning devices. Case managers are the major liaison people between the resident, the family, as well as the healthcare team. Any concerns raised by the family or by the team members, they are the ones who advocate for them. And we also have case conferences if needed because some families come with very unrealistic goals, which probably the resident is not ready to perform, or maybe they may not even reach that level. Such things are discussed along with the physician, and we have a team meeting to ensure that everybody is on the same page. We do have ongoing activities now. Since the weather is not good here, we've actually stopped these activities. However, until a month ago, physio and OTs, we used to do a lot of group activities, recreational physical activities outside. And now there's only, we've stopped this now till the weather changes, probably by September or October. And the task-oriented groups continue for male and female residents. This is being done twice a week for the males and twice a week for females in this majlis, which I mentioned a while ago. This is like an educational video, which we actually, after teaching the nurses, very often we still find that the patient is slumped in a chair, not in an appropriate position. Sometimes when they're brought to the therapy room, we find that they're not positioned appropriately. So this was just one of the therapists who created this video, which is actually played on the unit when required, so that even when you're walking down the corridor and you find a patient not in an appropriate position, you get help and you're able to align their position. The recent trends in elderly, community mobility, safe driving and driving cessation, assistive technology, and mood and emotional well-being. We try to incorporate as much as we can with the residents that we have here in our facility. And for safe discharge planning, as I mentioned, finding solutions for their everyday problems, adapting their home and environment. We actually do home visits to make sure that either if the equipment is received, that the space or rearrangement of furniture, getting the family to understand what we really are doing, and of course to enhance and promote better health for these residents. There's a lot of life transitions and role changes that occur, but the family is on board with most of them who are locally being discharged. And of course, risk management, falls, how to prevent falls in the home. And this is kind of a quality improvement initiative, which is done even in the community as well as even within our inpatient service, inpatient facilities. And the caregiver support is something that is of great importance, because the caregivers who are with these residents are the ones who will be looking after them right through, and even sometimes when they go back home. So we are actually training them and guiding them alongside while we take them for therapy, and they are the ones who actually manage even when, especially off-duty hours on the weekends along with the nurses. I don't think any of us are devoid of challenges in our lives. When we initially started, we had a lot of problems with professional attitudes towards long-term care, as well as regarding the collaboration of work. Many of us who have not worked in long-term care did find it really difficult. We have not had a unified geriatric program in all the hospitals and facilities. Of course, there was always a lack of manpower in the program. Clinical pathways have not been set. Not a formal sensory stimulation program or a cognitive stimulation program. And collaboration with community services was something that was still not completely established at that point of time. But of course, over the years, we've had a lot of positive outcomes, from hospital standards to long-term care standards, being able to see the resident in a better environment, from inpatient right up to the home. Even though we have had our overlaps and differences, the interprofessional and NDT, we've come a long way in our collaborative care. Having had these educational sessions, frequent MDT meetings, meeting with leadership, has really helped us work together as a team for the residents. We've had increased treatment resources in terms of wheelchairs, positioning devices. The custom-made devices require a lot of material, which the administration, once they've understood, they've also been very supportive in providing these materials. The residents have, those who are active are brought out together, and they have breakfast groups and with all the residents in that particular unit, as well as we have ongoing group activities, therapy for those who are not attending therapy on that particular day. We try, a daycare facility has been started for residents who come out, for patients who come out as outpatients, and that is in the outpatient facility. in our inpatient, because there was so much of, everyone seemed so stressed with the type of patients you're treating and the type of things that we do. We even had a best unit and staff recognition, one as part of PCC standards, as well as best unit. We just created this by encouraging all the staff in the unit to work in collaboration with whatever goals were given by the therapist or by the MDT team, and whichever unit was able to establish themselves and do well, they were actually rewarded. So this has been a boost for staff, for the team working together, and for the unit, because there's a greater sense of belongingness. We have had some national strategic plans which has gone through with the Ministry of Public Health, which is the governmental system, and we've done dementia as one of them, where early detection surveys were done. National guidelines, we were part of the national guidelines for dementia. During the Alzheimer's month in September, we've had awareness campaigns, we've had campaigns outside. Initially, it started with the community, and there's a lot more awareness. And then the next year, 2 years ago, we had it within the hospital so that everybody is aware of how to go about and having collaborative care. Mental health, seating services, and community equipment services, and community services, these are all part of strategic plans, which is ongoing right now. Our departmental strategic plans, we do still look forward to unifying the geriatric program in all the hospitals and facilities to try and increase the manpower in geriatric and the long-term care program, to establish clinical pathways between the facilities, and we're also working on a guidelines for contractor management. One of the things they're looking forward to is to have a supervised daycare gym. We do have that in the rehab facility, but they would like to have one for continuing activity programs for the elderly as part of continuity of care. I'd just like to share a few small project ideas which probably you could think of in your own areas wherever you're working. As part of quality improvement, I think in hospitals, we all have quality reviewers who actually come and we are able to sit together as a team. But when you're alone and you want to make small changes within the setup that you are in, I'd just like to share, this is just one or two small ones which we did right at the start. We had various monitoring tools. This bed positioning was one where we provided these devices, positioning devices to the residents in bed, and the nurses needed to use them appropriately in the right position. Especially if there are some devices provided just for side lying, it had to be used only in side lying. If it is in supine, then those are the pictures that we've taken, and we used to put a time, but this is done in collaboration with the nurses. And then there was a monitoring tool done to ensure that this individualized positioning schedule could be actually followed. Another one we did was for pressure injuries, a safety monitoring tool. From the time the resident is transferred from the bed to the wheelchair, because you're using a hoist, you're using equipment, just wanted to make sure that the resident is safely transferred. And from the room, when they come up to therapy, the nurse inspects all the exposed areas to see whether there are any injuries prior to sending the resident to our therapy area. Similarly, the therapist on receiving these residents would actually inspect all the areas exposed, and just to ensure that there is the patient is properly seated, safety belts, and all that is required to monitor, even for pressure injuries. This was done through a safety monitoring tool. So these are just small things, project ideas, which you can think about in your own areas. Even if you're alone, it's always good to go through and study the system, basically for us to try and see how we can improve from where we've started. The way forward, I mean, all of us have gone through this pandemic. Of course, now there is much greater acceptance of the near normal lifestyle. We continue to improve the quality of life for these residents. Now, of course, restrictions have been lifted up here. Most of our residents are vaccinated, most of the healthcare workers, but we still continue with strictly following the infection control practices. We facilitate and continue patient engagement through activity and social participation. And of course, we have not stopped focusing on safe discharge planning home along with the MDT. These are some references. I'd just like to show you a video when we initially started. Maybe an updated version will be shown during Ben's presentation. This is just to show you how we started off about almost 6 years ago, collaborative care with the physiotherapist. I just have a few key takeaway messages. You know, it doesn't matter how many resources you may have, but if you don't know how to use them, believe me, it will never be enough. Never be afraid. This is Barack Obama's quote. Never be afraid to ask questions. And don't be afraid to ask for help when you need it. I think most of us, or some of us, may be practicing this every day. Asking for help isn't a sign of weakness. It's a sign of strength. It shows you have the courage to admit when you don't know something and to learn something new. I think most of us experience this. Every day is a learning experience for us. So trust that God is bringing every person, every lesson, every opportunity into your life to get where you need to be. Thank you. And at this point, I just want to thank my chief, Mr. Sultan, and all the supervisors, and especially my dedicated teams who have really brought this journey of ours in long-term care in Qatar this far. Thank you for this time.
Thank you, Lincy ma'am. I found two things in your presentation really, really useful. The first was about how you classify the patients. So one of the things that I find really challenging is that, as you said, by the time they come to us, there are a lot of comorbidities. Sometimes it's difficult to prioritize. Sometimes we find that there are very few modifiable factors. But when you showed how you organize them into cognitive, according to mobility, according to sensory motor, I got a clear idea of how to go about that better. The other thing that I really found helpful was at the end of the presentation, when you talked about the small project ideas. I think all of us should think about it, whether we are in an institution or working by ourselves. I thought those were good ideas to go forward about how we do our interventions. We'll go now for a round of questions.
Thank you, Reema, for that, because, I've also worked in mission hospitals and, been in Bombay, in Coimbatore, and then I came here. So seeing the place here, we think everything is glorified when it's abroad, but it's not like that. Life is a challenge, especially in hospitals where, we're just beginning to start up. And it's been a journey for us because really this was a difficult thing for us to come up with a guideline which was more suited for our residents. So thank you for that. Any other questions?
Hi, ma'am. This is Vimal, OT from batch of 96. I've always been an admirer of your work and Ben's work over there, and it's fascinating to see what you do there. It's absolutely brilliant. I have my background is in geriatric medicine, especially when I've worked in the UK. One of the issues that is coming up now, especially, is how do you deal with multiple long-term conditions? So it's not just one particular aspect of, if they have dementia, but they have dementia and arthritis, or they have dementia and cardiovascular disease. How do you manage that in your client group? Does it come up? Does it impact on how you provide rehab? Especially with someone with, say, cognitive difficulties, but then you're discharging them home, but they have to take multiple medicines for other conditions they may have.
So like I mentioned, this you're perfectly right in saying that we actually have many of them who are admitted with multiple comorbidities. But for example, let me tell you, even for seating, for example, if we take somebody just with as simple as having an NG tube, okay, you are considering whether there is a risk of aspiration or is proper positioning going to be your priority. If it's a ventilated, ventilator dependent patient. So similarly, with conditions like you said, whether it's arthritis or whatever, we go by mostly symptomatically. We'll have to look at their level of functions. We have to look at what the resident is able or the patient is able to tolerate. And then we try and adjust our goals, because if we go with our professional goals, one thing I've realized is we fail. Sometimes patients are the ones who can teach us, those who are vocal. Sometimes the family members are able to give us ideas. It could be even sometimes a co-worker. So looking at the priority of the condition, the level of function, and of course, their tolerance to activity and endurance. I think this is important for us to consider. And like you said, regarding medication and other things, all this is actually very closely monitored by the MDT here. And that is why we have these case conferences. Sometimes we might think that the tone is increasing. So we ask them to, start them on baclofen or to give them Botox. So it works both ways. And that is where we've reached now, where we're able to share with one another. Sometimes the dietitian says, no, you're not supposed to do this. But, the elderly, maybe they just probably want to have maybe a little bit of additional sugar. They may be diabetic, but this is like, they've grown. So, they've grown over time. And then the dietitian says, okay, it's fine to do that. So in our activity, sometimes we have to look into that also. But it's a team approach. We don't try to take individual decisions, which is going to be harmful. I hope this answers your question, Vimal.
Yes, it does. Thanks for that. I just have one other question. I suspect it's because we are in two different health systems and how we think might be slightly different. The other thing that comes up fairly often here, again, for people who have cognitive difficulties, is the question of consent and how we treat people, how we look after people based on best interests. And a lot of that is, at least here in the UK, is guided by law. And we have to be very careful about what we do and what we can do and what we cannot do, especially if the patient cannot give consent and we're treating them in best interest. In your video and a couple of the pictures you're talking about positioning devices and restraints that you use to keep people upright in the wheelchair. How does it work in Qatar? Do you have like a legal system that guides you, or how do you actually go about deciding what is in the best interest for a patient?
Yeah, so coming to legal systems, yes, and we do have to take a consent, especially if the family is available. If the residents are, of course, they are able to vocalize, definitely we're able to get the consent directly. But for those whom we are, especially when we use it as educational videos or we want to actually use it outside, all their pictures and, if we're utilizing, we will just, if we don't have a family member, then for sure, we will, block their faces off so that you don't recognize them. And in terms of cognitive, we do have a lot of patients who are actually expatriates. So what we try to do is in simple things, if we are able to get either a family member or a friend who knows them well enough, these are people who actually help us in assisting us in, getting through to them. But otherwise, it's usually just the case manager, the physician, and then sometimes patients whom we have absolutely nobody, it might be the embassy who takes over for these patients. So that's how we manage this part of it. Does that answer you, Vimal?
Yeah, brilliant. Thank you.
Do we have any other questions?
Lincy ma'am, this is Jim from the batch of 2003, ma'am. I head the CBR unit of my place. It's called it's near Goa. About 43 villages I supervise. We have about 1,200 to 1,400 disabled population when it comes under my head. You've placed 4 to 5 aspects like the physical part, the cognitive part, the social, the emotional. But again, in a place like Hamad and really well established CMC Vellore Rehab Institute, this model is perfect, ma'am. But when you come to a developing country like India, where you have resources very minimal, especially when the disabled population is really huge, we do take care of the social and the emotional, we train them and all that. How much do you think the physical and the cognitive training will work in a setup like India, ma'am? Because, these are all like terminally ill people with spinal cord injured for more than 10 to 15 years and MR child with, around, say, 25-year-old MR child. So physically as well as cognitively, we're not going to get much. So we do have a social and social and the other parts we really take care of it. But the physical and the cognitive in a country like India is very much not a very developed country where you don't have resources. How much do you think we'll put the inputs and we basically don't get that much of an output also? So what is your take on, like, I know it's a very different country, the
people who can go to the homes. See, it's very difficult for them because one, like you said, lack of resources. Second, money to come to a hospital and to actually get that kind of treatment is really difficult. So what is the kind of, how are you extending your services to the family members or to the home for these children or for these adults in geriatric? How do you go about this?
We do it in 2 different models, ma'am. Yearly about 3 to 4 times. We do have, like how we have the rehab mela there in Vellore, ma'am. We do have short, about say 4 to 5 days of camp so that we train them both in physical and all the other things. And the other way is that I have about 45 people under the team that works along. So what happens is about a village is taken care by 3 staff, and another village is taken care by another 3 staff. So they go weekly around like at least 3 to 4 times a week. They visit the village, they visit the disabled person. So they directly have a hands-on. But I don't have a hands-on experience. I just share my experience with my team. So it goes like they send it through WhatsApp, they send all the information, then I correct it and then check, oh, these are things that you'll have to work. So it is both an IBR setup plus a CBR setup. It's
Yeah.
both ways.
Jim, can I just ask you that do you have any kind of support groups or any kind of training sessions for these staff who move? Yeah, like you said, they do a follow up, right? For 3-4 times a week, maybe they're going to these homes. So, do they have any kind of formal training to go about their work?
Yes, ma'am. What is the plan that I have made is that we do about monthly trainings for these team, and also what we do is all the differently abled, they have a group in the village itself. In 3 years, I've set up different types of groups wherein the heads of the group is differently abled only. For example, a
Okay.
person with polio becomes the head of the group. So he is able to cater to the needs of a person who is really, really terminally ill. Say a spinal cord injured for about 10 years. This man who's got a polio, he takes care of that person indirectly because he's always there in the village. So this model has worked for us.
Yeah, I was actually going to say the same thing because I feel one thing that we lack see, it's easy to do the training. Like you said, you can receive the problems, you can provide suggestions and recommendations. But the follow up management, which needs to be done hands on and on a consistent basis, I think that's where we lack. And unless we have adequate people to do this and they're trained to do this, I think that's where we fail. So I think you've done a pretty good job of having keeping people who are in charge of this, who are able to actually contribute to the homes, and I think that's a brilliant start, to be honest with you. So I think this probably helps because one thing that I've noticed even over here, it's not about it's a different country or whatever. Our challenges are very much like what I faced when I was in the mission hospital there, and that continuity of care and follow up is what is lacking. But if we have people who are constantly trained and we do a close follow up, I think that might be of good support both for family members as well as for the patient. I hope this answers because that's the only way I can think of how we can, recommending is easy, but actually doing hands on and trying to follow up, that is something that we always face as a challenge when we are back home.
Yes, ma'am. Thank you for that input. What about the physical, and should we really actually focus on the physical and cognitive? Because they're not going to improve that much greatly. And being in India, there are like they don't want to spend on something where they don't see great effort. But the quality of life when we do it in Qatar or when we do it in Vellore, like they are for quality life. But here, people, like surviving itself is a big deal. So should we really work on the physical and cognitive over here rather than just treat only on the social model and then the integration part? Should we really concentrate on the medical model?
Jim, if there is a possibility, I would really encourage